So just to talk about why we should care about transfusions and transfusion reactions, and I think this number for me was quite striking, is that transfusion is the most commonly employed procedure for hospital inpatients, and that's in American medicine, and I think our medicine likely follows quite carefully along with that. And there is increasing evidence that transfusion is in general less beneficial and more harmful than practitioners think it is. So infectious risks, and I think there's some people in this room who remember the Crever area, and there's some people to whom that was probably elementary school, if not nursery school. So the infectious risks, I think, stand high in a lot of people's minds, but actually are very minimal in the Canadian blood supply. They're not zero, but they are minimal. But the non-infectious risks like circulatory overload, lung injury, hemolytic transfusion reactions are more common, and they can affect multiple organ systems, and they are associated with worse patient outcomes in a number of studies, up to and including death, which is fortunately not particularly common. So just to talk about a case, and this is a real case. So this is an actual case that was reported to our health region, which I'll talk about the structure of that later, from another health region, about this time last year actually. And it was a 91-year-old woman who was transferred from her hospital to her nursing home for assessment. I think they were having difficulty managing her pain. And on admission, her admission hemoglobin was 83. So her doctor ordered 2 units of Paxils for transfusion, and the cross-match was performed and the first unit was issued. And her pre-transfusion vitals, I think, were reasonably stable. And I hopefully all the nurses in the room would agree, and they'd be happy to start the transfusion, and so they did. And then at the 15-minute vitals, the RN went back and checked on the patient, and she found her feeling unwell. She was shaking, she was retching. She wasn't shocky, but her pressure at least was holding in there. But clearly something was the matter. And so the transfusion was stopped, and Benadryl was ordered and given IV push, and a transfusion reaction workup was initiated, and the lady was moved to the OBS unit with a normal saline bolus running. So eventually this is what came back. So this is an example of a clerical error. So there were two older ladies with similar names in the facility that day, and one was O negative and one was A positive, and the samples had been switched during the workup. And as you can see here, we have visual hemolysis in the sample, a positive DAT. This is the recipient's blood group, and this is the donor unit. So all of a sudden that went from a fairly routine procedure to a whole world of hurt, an old lady not doing very well, being hustled down the hall to the OBS unit, and potentially having a bad outcome. So that's why I'm here to talk to you today about transfusion reaction, because it really was the nurse at the bedside who caught that. And it just emphasizes, I think, the really, really key role that the transfusionist plays in transfusion safety from vein to vein. So I must give credit for the original slides prepared a number of years ago now by Dr. Constantine, who is a transfusion medicine fellow in Halifax where I trained, and I've updated the statistics of late. And it's largely based on the approach in Bloody Easy 3, so that reference will be at the end, and it's a fine reference. I couldn't possibly improve upon it. So we'll talk a bit about major acute transfusion reactions, because I think that's your concern at the bedside. I mean, if something happens 1 year later, obviously that may be picked up, but it's not in the scope of the transfusionist. So acute hemolytic transfusion reactions, which is what that was, allergic or anaphylactic reactions, febrile non-hemolytic reactions, transfusion-associated or related lung injury, and transfusion-associated circulatory overload. And briefly touching on some of the more acute infectious presentations. And taking a symptom-based approach, because obviously people don't present with the label taco on their forehead. It has to be worked out. So again, what's the importance of identifying and reporting transfusion reactions? I mean, transfusion can kill people. It rarely happens. And I'll talk a bit more about the morbidity associated with transfusion later. And the fact of the matter is, if we don't track the problems, we can never solve them. So I remember reading an ASH, the American Society for Hematology education book, in their 50th anniversary. And they had these great historical perspectives. And this transfusion expert from Bethesda, the NIH, talked about the risk of hepatitis in transfused patients in the 1960s. So does anyone want to throw out venture a guess as to what the risk of hepatitis in the early 60s was if you got a transfusion? 1 in 10. 1 in 10 people got, in the American blood supply, which is just, like, I don't know why anyone consented to transfusion. So I think if people hadn't been kind of making notes, God, geez, boy, a lot of these people are turning yellow, they would have never discovered the testing. And the guy, actually, he was the one who discovered the test for Hep B, the original kind of old style test. So, and I think more recently, there's been problems with hives and IVIG. And again, if people don't notice that, these severe hives, and report them to the blood bank, there's nothing that can be done. Again, so that's where the issue of recognition and reporting becomes so key. And I mean, there is no other relationship for the transfusionist at the patient's bedside in, you know, knowing your patient, knowing the clinical setting, knowing how they're doing, and then reevaluating them as the transfusion proceeds. And that's why I put this pair of eyeglasses, because your eyes are on the patient. I mean, as far as we knew, it's packaged up, it's gone out, okay, everyone's happy, and until we know otherwise, that's our impression. So this form, and oh, actually that predicts better than I thought. So, I mean, there's a number of forms, and eventually we're all going to standardize to this. So I use this because that's what we're using now in Regina Qu'Appelle. And this is what is so helpful, because it's you guys putting the reaction into its clinical context, letting us know what the vitals are, how it looks, and then just what else is going on with the patient. Did they have a pre-existing fever? Are they in fluid up to their eyeballs, etc. And then we do our workup, which is basically what you'd seen earlier. So again, the clerical check, looking for hemolysis, a DAT, and reconfirm the ABO/RH typing, which in our case, unfortunately, proved very productive. And so, I mean, where do these forms go? Like, oh, geez, another form to fill out. You guys are all busy. So what happens is we take that information, we'll report it to the Transfusion Transmitted Injury Surveillance System, which is a federal system. So, but not only that, because all the provincial reportings funnel through Saskatoon Health Region RQHR, we can take data, and we have taken data to inform provincial initiatives in transfusion safety. So I think for our case, actually, we're advocating for at least technologist access to transfusion history, because clearly if one had been able to look up her history, she had a historical blood group in another health region, which was consistent with her real blood group. So that would be an added safety benefit. I don't know if any of you got the letters, and those of you out in peripheral sites might have gotten letters for, there was an incident where a patient received a dose-expired Winrow. So that we took that and immediately turned it around and sent out a letter and had everyone check their inventory. So hopefully, as we learn these things and as reports come in, we learn where the risks are to the patient, where the holes in the Swiss cheese are, and we can start to ameliorate them as a system. And then that then proceeds at a national level in terms of understanding trends, which allows us to produce charts like this. So should you be asked, or should a patient want to know, or if the physicians are consenting, you know, to give people a realistic understanding of how common is it. So HIV, I think, is a very can be very scary, particularly to people who are familiar with the Creever era, but is actually very, very rare. Whereas you're much more likely to have circulatory overload or minor itch or a fever. So, I mean, I think that can put risks into context and help patients and their families understand. And then, so again, if you were asked, you could say, well, that's 1 in 400,000 transfusion episodes, which coincidentally is about the number of transfusions we do every year in Saskatchewan. So about every year, on average, this will happen. So this isn't like a unicorn that I mean, individually we never see it in our careers, but I probably, as the data collector, will see it again. And if it's related to the quality of the product, we do forward that on to CBS, or not Quebec, but in Quebec that would be, or the manufacturer. And the importance of that is it can lead to the quarantine of other affected products, or identification of a dangerous donor in the case of trolley, and I'll explain that a little later. So it is very important to understand that if there's a platelet that's problematic, there's probably a red cell and a plasma unit that are likewise problematic, and CBS, as Val is here, will get right onto that and set it aside. Okay, so in terms of acute transfusion reactions, I think as a blood banker, the acute hemolytic transfusion reaction is the great grave fear. And at least some of that is because sometimes it's on us as laboratorians. I mean, in that case, it was clearly on us. And so there's a lot of different causes, and ABO incompatibility, I think, is the big one. But just to let you know, as transfusionists, it's not just a red cell issue. So if you're transfusing a platelet or IVIG, there still can be acute hemolysis because the antibodies in the plasma or in the IVIG can cause hemolysis. So it's something to watch out for when you're transfusing different products other than red cells. And occasionally there's antibodies to other red cell antigens, which we could go on about at length, but I think that's probably what's going to keep my kids in shoes rather than spending all day talking about it. But there are other antibodies that can cause acute hemolysis. And then there's non-immune hemolysis. So if you're in the OR, if there's a hypotonic solution, if you're pushing blood in through a blood warmer that's not validated, if the caliber of the IV is too small. So there can be non-immune hemolysis as well. So those are causes to think about. Again, a 1 in 40,000 risk. So 50% of the time, there's a properly labeled product that's issued from the blood bank that gets mixed up on the clinical side. But that's not to say that the other proportion of the time, we've made the mistake and you guys are like, oh, look, this is Mrs. Smith's blood. I'm hanging Mrs. Smith's blood. And then all of a sudden, oh my God. So there's a mix of, I guess, responsibility, which is why it's so important that we all work together. Fortunately, it's less than 10% of the time it's fatal, but the longer it's allowed to go on, the worse patients do, which is why that 15-minute vital is so key. Because, I mean, the nurse came in, this lady had gone from stable to, clearly something was wrong and it was stopped. So if that had been allowed to go on any longer, that lady might have done way worse. So again, she had, in some ways a classic presentation. So fever, chills, hemoglobinuria, that classic kind of back and flank pain. That's the textbook presentation. If everyone presented like the textbooks, this would all be easy. But other things, like obviously if they're vitals, they crump their vitals, nausea and vomiting, shortness of breath, and then it can proceed and into renal failure, DIC, and obviously death. So here's our transfusion reaction algorithm, and I'm sorry this is kind of small, but don't worry, I will blow up the pieces. So this is kind of a general structure that we've provided to help sort of recognize what are sort of ho-hum transfusion reactions to, oh my God, hair on fire, as Judy says, transfusion reactions. So I think in terms of management, the key pieces are exactly what that nurse did out in that rural site, which is stop the transfusion. Do not throw the bag in the garbage. We will need it again in the lab. Maintain IV patency with a compatible IV fluid, and the vast majority of the time that's going to be normal saline with the exception of IVIG. Keep a very close eye on your patient. Let the physician know and they will tell you how to proceed as their best medical judgment. Clerical check. So please see if either we've made a mistake or you've made a mistake, because of course there's another patient out there. So if we've got units that are switched, there's another patient that may have another wrong unit just sailing out ready to hurt them too. And then do let us know, and depending on your local policy, and in our QHR and eventually everywhere, it will be the transfusion event. Basically, clerical discrepancy or incompatibility is a flat, obviously, stop, and then there'll be a decision how to go on further. So this is what I tell my medical students when I teach them. So do ABCs, vitals, IV access, fluids to keep their urine output going and their kidneys working. Treatments for symptom relief, as you would indicate, and I think a lot of these probably would be PRN orders for you guys. Acetaminophen, Benadryl, oxygen. I always remind them to consider whether or not the individual needs a higher level of care. Let us know, and then we'll all work together to determine if it is an acute hemolytic transfusion reaction. So I've divided this up. So there's things that we can do in the blood bank, and there's things that if you're in a smaller site, you can do it in a more limited site. So if, for instance, if you're working out somewhere where the red cells are packaged, sent out to you, so that you're a peripheral site, rather than like we have some here in Regina, Qu'Appelle, Indian Head, Wolseley, and Broadview. So those labs are limited. They wouldn't do ABO typing, and they wouldn't do a direct antiglobulin test. But I mean, every lab, should be able to do the clerical check, which probably some of you would do at the bedside, and do a visual check of the serum for hemolysis. So clearly, I mean, this is nice straw-colored plasma, nice and normal. This is probably somebody who didn't survive. So I mean, if it's somewhere in the middle here, that is very concerning. It doesn't prove the cause, but it is very, like, that is hemolysis. And a urine sample also, if you're in a smaller or rural site, because people, their urine may take on the same color as their plasma. Ideally, like depending on the size of your facility, so if you have an in-house transfusion service, obviously we do a direct antiglobulin test to prove that an antibody caused it, not the small bore IV, the blood warmer, etc., and then do an ABO confirmation. And sometimes if these things seem repetitive, then you get a case like Our Lady, and it shows you why that's important. So this lady, she did very well. I mean, boy, that physician could not have managed this situation better. And she ended up back in her nursing home, and she didn't even have a change in her creatinine. But it can kill people, and I don't want to digress too much for the interests of time. So, I mean, for those of you who work here in Regina, how many of you know Dr. Rao? Yeah, okay. So he looked after a patient. It wasn't his patient, but he had to, I guess, clean up the difficulty, as it were, for a double lung transplant patient who was in a critical care unit, not in our center. And this was, this is at obviously double lung transplant. This is a high-level ICU care center. And there was a clerical error, and the lab sent out the wrong blood. And it got hung, and the patient ended up going into DIC and dying. And he described it as the patient bleeding out their eyeballs. So this was a young father of 2, and he died. So I think that is why it's just, this is just so incredibly feared by blood bankers, and it's so incredibly important to have your eyes on the patient very early on. How to prevent this? So I find sometimes as laboratorians and nurses, we sometimes enter into this battle where you guys have gone to a lot of effort to get a sample, you know, like Jerry Bell talking about sticking someone in the neck. And, you know, God, obviously this came from this patient. And then you come to the lab and we're like, oh God, you haven't put all the identifiers on here. Boop, go do it again. And you're kind of like, well, you know, I just stuck a needle in someone's neck. That was a lot of work and I don't think I can do that again. But the problem is we don't know that and we didn't see that. And everything we do predicates on the trust that the blood in that tube is Mrs. X's blood. So does anyone here remember there's a case, you know, in our Emerge where there were 2 trauma patients running and one of the trauma patients got blood for the trauma. And that's why we get really fussed. We're not trying to be disrespectful of the fact that you just jammed a needle in someone's neck. It's that we don't want to pour gasoline on a fire by potentially making something worse. Careful sample handling and testing. So again, this was in a setting where we had, I think, a junior staff who was multiply distracted. You know, here, there, page, stat page, this, that, the other thing. So very difficult to do standard work. Selecting compatible products, which is theoretically our job in the blood bank. And then re-identifying the patient at the bedside. And again, like, you guys, there's the final hand. Like, if we have made a mistake, and let's say, or the porter's made a mistake or whoever, and we sent out blood for Gordon Smith and, you know, there's an Adele Smith and it's going to Adele Smith, like yours is the final set of eyes, that final hand that can divert that disaster from occurring. So yeah, again, so that's why we get fussed and it's not because we're anal, although yeah, usually we are in the lab, but it's because we never want to pour gasoline on what's already a really unpleasant situation. So I think what we're asking is if somebody donates blood and they do come up with a positive, and I'm guessing you're kind of thinking of an infectious disease, what happens is, yeah, definitely that donor will be deferred permanently, I believe, and I'm looking at Val Paulson, who's from CBS here, and they'll definitely be made aware, because I mean these are very treatable diseases now. So yes, no, that's a good point. Okay, so then I guess we get into, so that's the scary, bad one, which is fortunately, you know, rare, but once a year. And then we're getting to things that are more common. So once we're out of the realm of hemolysis, so all of us in the lab are like, ooh, okay, back to you, clinical side. So febrile reactions, so obviously they present with a cardinal symptom of fever, not uniquely fever, but I mean, I think probably for those of you who are experienced transfusionists, that's a fairly common presentation. And so the non-infectious causes and then an infectious cause. So febrile non-hemolytic transfusion reaction, and I can't sign off countless ones of these. I don't know, how many people here have seen a febrile non-hemolytic transfusion reaction? Yeah, and Elaine and yeah, Doug. Tons of times, right? So quite common on the oncology wards because it's more common with the platelet pool. About 1 in 300 red cells. And the cause is thought to be cytokines in the component or maybe some antibodies in the patient against donor white cells. I'm not really convinced that that's a meaningful cause in our Canadian blood supply. I've never been given a satisfactory answer, so we could talk about fairies or God or viruses or, well, it's not viruses, but so, I mean, it's just something in the blood that causes a fever, and cytokines are pretty much it, wherever they come from. Up to 6 hours post-transfusion, and they may just have the rigors or they may just be nauseous. So this is kind of a bit of a grab bag category. And it is a diagnosis of exclusion. So this is where it's only minor symptoms, and I'll talk about serious symptoms later. So if it's just a bit of a temperature rise, but it hasn't hit 38, and there's nothing else going on, they're sitting up in their bed, they're eating vanilla pudding, chatting with the family, watching the Riders game, and the onset's greater than 15 minutes into transfusion. So we're not thinking as much that it's one of the acute hemolysis. certainly can stop the transfusion, obviously, give them some Tylenol, see how they react, and then carefully resume transfusion if all the bad things have been ruled out. Please do report it to us. And then obviously if there's serious stuff, then it's a full stop. Demerol can be considered for severe rigors, and pre-medication, everyone does it. There's no evidence for it. That's how it is. Okay. So then febrile reactions that have a more serious or infectious cause, just trying to keep it weather on the time here. Also more common with platelets. I think these numbers are probably now in 2014 a little lower. But, you know, certainly very unlikely with red cells, but, you know, not outside the realm of possibility. Bacteremia, skin flora in the donor, bacteremia in the donor, and there's actually a case here in Regina, Qu'Appelle that was a bacteremic donor, ended up, I believe, in close clinical proximity to the recipient, if I'm not mistaken. Am I right, Judy? Yeah. If it was mishandled, and I would say this is vanishingly rare, and I'm trying to be, our partners at CBS run a very clean shop. I mean, sepsis, like any kind of sepsis, kills people. So these are people with fevers who are sick. And I mean, I think you all well know the difference between, you know, okay, a bit of a fever looks great, eating vanilla pudding, to, you know, shaking rigors, crumping their pressure. So we've given a fairly long and comprehensive list of symptoms. And I think probably this is perhaps of more use early in one's career, and then as one goes on in one's career, it's just that kind of spidey sense of, that person's not right. But I think, again, rigors, tachycardia, hypotension, nausea and vomiting, shortness of breath, and it can proceed into DIC. It can be delayed if the bacterial load is small, okay? And what needs to be done in terms of other things is culture the patient, and we will culture the product. Because if you culture the patient, it comes up with bacteria X, and we culture the product, and it comes up with bacterial X, we find it's on CBS, right? So that's the smoking gun, that's the proof. And if the bag is clean and the patient has E. coli, well, then you have a cause for the fever. It's not on us, we can kind of sneak off, but still there's something that can be done. Okay, plus or minus antibiotics, obviously, in terms of management. We'll culture the bag and we'll let CBS know. Particularly if you see somebody spike a fever above 39, or they aren't responding to antibiotics, maybe just even let us know, like, this patient really looks bad, and then we'll kind of up our anxiety of our communication with CBS. Okay. So any questions about things? So fever, I mean, it can always be a hemolytic reaction. I always think that. But once that's out of the realm, it can be a septic reaction, which we hope it isn't, again, rare, and then a febrile non-hemolytic reaction, which is potentially unpleasant, but mostly a nuisance.
How do we distinguish that? Like in our work environment, we have people that have fevers all the time, or, you know, and then
it's really a diagnosis of exclusion, and and what I sign them out as, you know, possible febrile non, as long as other causes of fever ruled out clinically, because like post-op fever, I mean, you know, wound water, wound walking, like it could be many, many things. So again, I think the important thing is when somebody spikes a fever, especially a good going fever over 38, is like, for the love of God, let's make sure they're not hemolyzing. If they're looking really sick, we should culture the product, especially if they're getting platelets. So would you guys be big platelet transfusers, or mostly? Yeah.
But I can honestly say in my entire career, I don't think we've ever done that. We've ever cultured platelets ever.
But have you sent them back? Because we culture platelets.
That's what I'm saying. Like that's our question, right? Like, so are we supposed to, every time we have somebody who spikes a fever that's in ICU that has a temperature over 39, we're supposed to send the platelets back?
If they're being transfused, yeah.
We definitely don't do that.
Okay.
That's something that we, yes.
Okay.
So, because that's something we've never, I can say I've never had platelets.
Okay. Yeah. Well, but that's what it is. Like, that's where, I mean, this one case, I mean, the donor actually ended up septic, and that was what was implicated. I mean, yes. Did I just shut that off? Okay. So I would say yes. Please do, especially if they get a temperature over 39.
This is Captain Arcola. What does CDHA mean?
Sorry, clerical check DAT, hemolysis, ABO, sorry, that's my little acronym for doing the post-transfusion workup. So we want to rule out that hemolytic transfusion reaction. Sorry about that.
Donna, one of the things.
Hi, this is a question from Tisdale.
Okay.
If you have a minor reaction, so say the only thing wrong is a temperature rise over 1 degree Celsius,
Yep.
and there's no other symptoms, are we to then maintain IV patency in a new primary line? Would we actually disconnect from the blood transfusion and maintain the IV access with the new line,
I would.
if that's the only symptom?
Yeah. I would. I mean, I think it can be occult, especially in a patient that maybe isn't a very good historian or might have other reasons to not have an immune system that's 100%. I mean, I think I would do that and at least do a check for hemolysis and do a clerical check, yeah. I don't know how much capacity your blood bank has in Tisdale. Do you guys have an on-site blood bank, yeah?
Yes.
Yeah. I mean, that would be my recommendation.
So we would follow the first box, steps 1, 2 through 6,
Yeah.
as the algorithm says.
Yeah, I would always kind of do that, and then if it turns out to be 3 hives, you can give them some Benadryl and try again. But I would always, I think, err on the side of caution.
Okay, thank you.
Okay. Okay. So any more comments?
I was just going to say platelets are the concern because they're stored at room temperature. So
Yeah.
if the donor has a small amount of bacteria in your system, we test all of our platelets for bacteria, but that will grow in the bag as it's sitting in the lab. So that's one of the reasons why platelets are a bigger concern than red cells.
Yeah. And there's a companion product too, unless it's an apheresis unit.
They're good for 5 days from the date of collection. And it takes about a day and a half for the test results to come.
Okay. So just for rural sites that people are asking about the shelf life of platelets, so 5 days from the day of collection, but probably 3 days effectively once they're in the inventory. Okay, so that's things that present with fever. Then talking about things that present more with itch and rash. So urticaria, so how many people here have seen sort of an allergic reaction to transfusion? I'm thinking some of the nursing students probably have too. Yes, no, okay. So about 1 in 100 in plasma containing components. And it can be either just, one isolated hive to a very widespread rash. And we've chosen in this province somewhat arbitrarily to say that that's less than a quarter of somebody's body surface area. And there's not a great basis in evidence, but I guess once somebody has about a third of their body covered in a rash, to kind of continue on as if everything is good, I think is a bit of a risky proposition. So again, that is an arbitrary number, but is chosen, hopefully to guard the patient's safety. And this would be, again, not associated with any other symptoms of a severe allergic reaction. So no respiratory symptoms, no swelling around their face, no stridor, no wheeze, no shortness of breath. So again, sitting up, watching the Riders game, eating vanilla pudding with some hives. So some Benadryl and then restart the transfusion slowly once a serious reaction is ruled out. But if we're entering into the a bigger rash with either upper respiratory symptoms or dyspnea or chest pain, hypoxia obviously, or or if they're starting to crump their vitals, that obviously is in a very different territory, and definitely is not a restart the transfusion time. One thing to note about this is they do tend to come along quite early in the transfusion. So again, making that 15-minute vital check really key. So these are about as common as, like the severe ones are about as common as an ABO-incompatible transfusion reaction. And fortunately, I mean, they are associated with mortality. And the underlying cause is either antibodies that the patient has to stuff in the donor plasma, so anti-IgA in an IgA deficient recipient, or whatever. So if the patient, if the donor ate a peanut butter sandwich, or maybe they took an aspirin and didn't tell the blood bank, and the patient is allergic to those things, that can cause an allergic reaction. There's been reports of passive transfer of IgE. I don't know. I mean, I think that would be pretty rare. But so again, stopping the transfusion, assessing and giving supportive care. If there's those serious symptoms that we identified, that's a full stop on the transfusion. And then Benadryl, epi, steroids, vasopressors, and maybe actually going to be looked after by those gentlemen at the back of the room in the ICU. Do let us know. So again, we want to rule out an acute hemolytic transfusion reaction, both for the benefit of the patient and for somebody else who might be hurt. And we'll do an IgA level because that's something we can fix, right? So if a person has anti-IgA and it causes anaphylaxis, we can wash red cells and we can give them plasma from IgA deficient donors. So that's something has an actionable item. So then in terms of other non-hemolytic reactions that present, and the cardinal symptom is typically dyspnea. There's transfusion-related acute lung injury. So this is, I think, an underreported condition. Like, it seems to have waves of reporting. And it's thought to be about 1 in 10,000 transfusions. But CBS has done a lot of work to mitigate the risk in the Canadian blood supply by getting plasma products from males or nulliparous females. So the cause is basically you have primed lungs with a lot of leukocytes in them, and then the antibodies against patient white cell antigens come in, and then they basically they activate the neutrophils, and the neutrophils go wild. So you get this non-cardiogenic pulmonary edema, like the whole pulmonary vasculature becomes very, all the fluid passes across into the alveoli. And so what the concern here is the dangerous donor. So dangerous donor is someone like me, who's a multiparous female who probably has anti-HLA antibodies from pregnancies, and those pregnancies can go into the unsuspecting recipient, activate those leukocytes, and create that situation. And there's other thoughts about biologically active lipids, but the thing that we can test for is anti-HLA antibodies. So that's why people like me are deferred from plasma donation. My plasma would be sent for fractionation because that's the risk. So, I mean, CBS has been very, very cautious. So acute lung injury, I mean, I hardly need to tell you clinical folks what acute lung injury is. Hypoxemia, the bilateral chest infiltrates, but non-circulatory overload setting. And so this is when, again, for the transfusionists, the bedside practitioners, where it's useful to validate with the caregiver whether or not they want a chest x-ray to demonstrate that, because that is actually part of the CBS diagnostic criteria. So if we're going to move on to doing testing for trolley, which is very high-end testing and quite complex, basically the patient has to be a textbook picture, and part of the textbook picture is a chest x-ray showing that pulmonary edema. So trolley obviously is new onset of acute lung injury during or within 6 hours of the transfusion. So if you're transfusing someone multiple products, which if you're managing a trauma or whatever you may well be doing, there may be multiple products that are implicated. And no other risk factors for acute lung injury. And however this patient comes, I mean, I don't know if people are transfused who don't have other risk factors for acute lung injury. So these people obviously get very sick and they need supportive care, and if they're, sent intubated, ventilated, go for care in the ICU, usually it resolves within 48 hours and they do really quite well. There's a mythology, I wouldn't say mythology, so if somebody fell before you and just screamed, oh, I have trolley, the thought is that diuretics are not helpful, but I think that that's a rare patient that presents that cleanly without any confusion around circulatory overload. And maybe the intensive care folks in the back, like I've been told by the intensivists that they run these folks really, really dry. Has that changed at all? So I don't think a therapeutic trial of diuretics is necessarily a bad thing because they're going to end up dry anyway. So do let us know, because these are the people, especially if you have a very high suspicion, that we should let CBS know, because there is some kind of dangerous donor potentially floating around out there. And they will do the trolley investigations. And again, they set the bar very, very high, so it has to be a textbook case for the investigations to go ahead, but not for product quarantine. Okay, so then other things that are common that present with dyspnea would be circulatory overload, which I'm sure everyone in this room has seen. And I believe in the 2014 statistics, this is actually more common. So obviously it occurs at the extremes of age, so the very young and the very old, and euvolemic anemia. So the person that walks in that's had the chronic GI bleed, who has a hemoglobin of about 30, but is otherwise euvolemic. So if the patient's cardiac or renal function can't tolerate the load of fluid, or if the doctor is being a little aggressive in the transfusion rate, and it will look obviously like garden variety fluid overload, shortness of breath, tachycardia, increased pressure. So the management is to stop the transfusion, to see if they are seriously sick, and I'd say really almost any dyspnea is serious. Give them diuretics and oxygen as they needed. I mean, if you can, if they feel much better, you could consider restarting at a slower rate, but remember that the red cell unit will basically expire at the end of 4 hours. So, if you have to waste the unit and get another one, then I would sooner that than try to push the envelope. One thing we can do is in some sites, and I'm just going to say some sites, so here at the General, in the Pasqua, and in Saskatoon, we have the ability to split units. So if it's somebody who desperately needs a transfusion but just simply cannot tolerate a rate that would get a whole unit in within 4 hours, then we can split units. And then I guess then the final one is hypotension, which can be a bit of a nuisance, and again is a bit of a diagnosis of exclusion. So it's issues with bradykinin metabolism, and very often obviously associated with ACE inhibitor use. And it's a diagnosis of exclusion, so a transient drop in the blood pressure, which may be associated with some more serious symptoms. But on the whole, I would be hesitant to call this if it wasn't anything other than a textbook patient who dropped their pressure, otherwise felt okay, didn't have anything else going on. It came back up and they were obviously on an ACE inhibitor. So I think it's like any drop in blood pressure, stop the transfusion, institute supportive care. Let us know so we can rule out the scary causes of drop in blood pressure, or at least that are scary to us, like an acute hemolytic transfusion reaction. I mean, if there's additional fever, then we would want to think about sepsis. And then based on Dr. Richardson's advice, because I mean, people generally aren't on ACE inhibitors for grins, I mean, they're not something that you can necessarily hold lightly, is that they certainly could be held the morning of the transfusion or an alternate drug, antihypertensive considered. Okay, so I think I've talked a lot. So we have, I think, about 10 minutes left. So let's just, maybe go through a few cases. And I think that'll probably be dependent on the people in the room here, but don't hesitate to shout out people in peripheral sites. So in an 85-year-old woman who's post-op for hip and becomes short of breath with the red cell transfusion. So what is our initial management? Yep, stop the transfusion. Okay, so we got stop the transfusion. rip the IV out of the arm? No. So Tisdale, shout it out. You guys had that idea. Oh, they're on mute. Okay. All right. So keep the line open, ABCs, vitals. So what's the differential for a patient who's short of breath? So what are our possibilities at this point? I see people's lips moving, but I'm hard of hearing. What?
Circulatory overload.
Fluid overload, yeah. Fluid overload, excellent, thank you. Okay, sorry. PE. Yeah, no, this is true enough. Okay, sorry. This is a very focused presentation, so definitely she could have a PE of all kinds of atelectasis. Okay.
Anaphylaxis could be there.
Yeah, it could be. Yeah, no, it definitely could for sure. Okay. Anything else?
And then acute lung injury.
Yeah, acute lung injury. Could this be an acute hemolytic transfusion reaction? You're sure?
No, not good.
Are you sure?
Shortness of breath should not be there.
No, I wouldn't. It's not ruled out. So so okay. So all right. So Rose, can you? So here's Rose. Shout out. What are you doing? So.
Oxygen.
Yeah. So clerical check, hemolysis, ABO. Okay, good. So.
Give oxygen, diuretics if fluid overload.
Yeah. Okay. Very good. So we've ruled out a hemolytic transfusion reaction. I think that's some useful management points. So we've ruled out hemolysis. So I think, yeah, again, it depends on the clinical setting. I mean, there's many causes of shortness of breath, but this is just a ridiculously focused on transfusion associated. So this lady would be, I think, a reasonable setup for taco. You know, older lady, maybe's had some fluid before already in the OR, not great heart or kidney function, and then the therapeutic trial of diuretics. And as you said, well, you know, you don't want to see rash, stridor, and other kind of signs of allergic reactions. So trolley would classically present more suddenly with, you know, that sudden severe respiratory compromise. These people, again, will they respond to diuretics? Not classically, but probably that would be a therapeutic trial, definitely an 85-year-old lady. They'll probably need to go to the care of these folks in the back of the room, may need to be intubated. And so these are more likely to be young patients. So, and again, as this gentleman said from Redverse, and thank you very much, you know, the allergic symptoms would be important to assess. So urticaria, changes in their vitals, stridor, wheeze, lip swelling, and then obviously the chest x-ray will look quite different. Okay, so then if we're looking at a febrile patient, so a 25-year-old male oncology patient who becomes febrile with platelet transfusion. So again, initial management is stop the transfusion. Okay. Tylenol, okay. Okay, all right.
And rule out hemolysis. Rule out hemolysis. To
Okay.
rule out hemolysis.
Yep, I think, yeah, that's good. So hemolysis, I think, especially with fever, is something you always want to consider. Okay, so let's go. So Janine now is doing the workup. So we've done the clerical check. It's okay, no hemolysis. The ABO's confirmed the DAT's negative. Okay, Janine can go back to her. So again, I think the gentleman from Redverse had talked about some other things. So then once we've ruled out hemolysis, febrile non-hemolytic, so more likely with platelets, but otherwise not as sick. So again, your comprehensive clinical assessment. And again, this is where, you know, following their vitals, are they getting shocky? These people, again, may need to progress to a higher level of care and look sicker. So this actually, I think, was a real case. So this was a 55-year-old lady who had mild factor 11 deficiency. And she was so uncertain relationship to bleeding, but going for a partial nephrectomy, which has a fairly certain relationship with bleeding. So she got a plasma transfusion and ended up with a rash. So initial, what does everybody want to do? Stop the transfusion. Okay. Anything else you want to know about? Guys, I'm really hard of hearing, so people need to shout.
So rule out hemolysis again.
Yep. I love the way you think. This is, yes, excellent. Okay. Right, exactly. So keep the line open, ABCs, vitals, because obviously you're going to proceed very differently. So, all right. So I think then we'll have our lab staff. So now Noreen is busy. So we've ruled out an acute hemolytic transfusion reaction and then proceed based on our other differentials, which are basically minor allergic or severe. And so that's when, you know, getting some exposure, seeing how big the rash is, and then otherwise assessing their respiratory function, particularly, you know, any kind of swelling or concerns around the face or upper airway would be a definite red flag, and of course unstable vitals. And so those people obviously, you know, can't just give them Benadryl and continue on. They need more active management. So our last case then is another one. This is from Halifax. So a 7-year-old male, and he'd had a radical prostatectomy, and they wanted to top him up before discharge. So let's just get this guy buffed up and ready to go. And then he crumped his blood pressure. And so that was kind of a bit of a barrier to discharge. So, so let's say he dropped his, like, I think it was 30 systolic or 35 systolic. So initial management. Okay. All right. Yep. So stop, keep the line open, ABCs, vitals, et cetera, et cetera. Okay, so in terms of things it could be, so somebody dropping their pressure with no other information. So what are our possibilities at this point?
So what's the heart rate? Yeah. If it's bradycardia, then we have to see it.
Yeah, let's say he's mildly tachycardic.
Okay, but that rules out the bradykinin thing, you know.
Okay.
And other things.
Yeah, no, true enough. So, well, let's just say 95, just barely. Okay. Yeah, no, I think that's a good point. So we've done a workup because he's dropped his pressure to rule out hemolysis, and then I think there's a lot of things. So there's bad things, and then there's the bradykinin. So this gentleman, I think he ended up having nothing else, and he had his ACE inhibitor that morning. So in that case, I mean, the cultures on the unit were negative, and he didn't have any other symptoms. He didn't have a rash. He didn't have any respiratory symptoms. I think his heart rate was borderline. So anyways, that was what we finally, but it was quite a lot of investigation. So, I mean, obviously we want to rule out bad things, patients who are sick or with fevers or so forth. Anyways, so I think we're almost coming to the end of our time. So here are some resources. I think Blood Easy 3 is a phenomenal resource. It was developed by the Ontario Blood Conservation Group, and it is really one of the best resources, I would say even internationally, for transfusion. If you want a lot of detail, the CBS Circular Information goes into great depth describing the products. The National Advisory Council on Blood and Blood Products provides a number of guidelines on things such as IVIG, prothrombin complex concentrates, and other things and that are available. And we are working on getting a Saskatchewan TM homepage. So I guess if people want to have their questions answered in real time, the consultation's available through Saskatoon and Regina at the numbers here. And we have an admin support, so if people want TM resources, so we have a series of, we have pamphlets and posters and so forth that can be obtained. And if you want to specifically ask me about this lecture, these are my contact information. So anyways, thank you for your attention and for your phenomenal participation. Very much appreciated.